Hi, I'm Dr. Pam Peterson from the University of Colorado in Denver, and I'm here with Dr. Kathryn Lindley from the University of Washington in St. Louis. We are both participating in the session at the upcoming virtual QCOR conference on quality improvement in rural healthcare settings. This was a session that was developed in part in relation to the AHA's presidential statement that came out around February, was published in March, about the importance of rural health and furthering the AHA's mission of improving life expectancy across the health span by 2030. In fact, in that presidential address, they note that there's an average 3-year gap in life expectancy between rural communities and urban communities, with much greater rates of cardiovascular and stroke mortality in the rural communities. In that upcoming session, we will have talks on an overview of the presidential advisory, as well as covering telestroke in rural areas and disparities in congenital heart disease based on proximity to specialized medical centers. And Dr. Lindley will also be part of that session, and we'll be talking on maternal cardiovascular mortality. The AHA presidential initiative really calls for innovative solutions to address social determinants of health, as well as lack of healthcare services in the rural settings. So Dr. Lindley, thank you so much for being with us here today. And could you tell us a little bit about what you've been learning about cardiovascular maternal mortality in the rural settings?
Absolutely. So my practice is really focused on taking care of women of childbearing age who have cardiovascular disease or cardiovascular risk factors. And so I have the opportunity to take care of women in both urban and rural settings with those conditions. And what we're learning is that, unfortunately, maternal mortality across all settings is increasing in the United States. And in fact, cardiovascular disease is the leading cause of maternal mortality, accounting for about 25% of those maternal deaths. And that's true across both urban and rural settings. And the other thing that we've identified through state maternal mortality review committees is that, in fact, about 2/3 of those deaths, including those cardiovascular deaths, is about 2/3 of those deaths are actually preventable. There are a variety of reasons why rural maternal morbidity and mortality is very elevated, and in fact, appears to be perhaps the highest levels in the country after accounting for other potential mitigating risk factors. We know that women living in rural areas have higher rates of teenage births. We know that women living in rural areas have high rates of poverty and or underinsurance. And women living in rural America also have very high rates of cardiovascular risk factors such as tobacco use, obesity, and physical inactivity. Importantly, these women also have very low access to both primary care and obstetric care, as well as subspecialty care. So women with cardiovascular disease or cardiovascular risk factors who require complex multidisciplinary care with complex heart care teams, pregnancy heart care teams, face a real challenge in trying to receive ongoing multiple visits for complex managed care throughout pregnancy, and importantly during that postpartum period, which we now coined the 4th trimester and really view as important, if not in some ways even more important than during pregnancy itself in terms of considering cardiovascular disease and long-term cardiovascular health. I think that we have a long ways to go in terms of identifying and solving this problem, identifying the solutions to this problem, because they're going to be rather complex. I think some of the key solutions are going to be, number one, education, both of our patients, to help them recognize what those cardiovascular risk factors are and what the symptoms are that they need to seek care for, as well as educating our clinicians in rural communities to help them identify those cardiovascular and obstetric complications when they see them, so that they can promptly transfer those patients to clinicians who can provide the appropriate care. Number two, we're going to need to likely see some policy changes to help improve insurance coverage to these high-risk women who have very high rates of underinsurance and who oftentimes lose their insurance 60 days after delivery, which eliminates their ability to receive ongoing care in the postpartum period. And finally, we're definitely going to need to identify some innovative solutions to provide coordinated obstetric care, cardiovascular care, and primary care to deliver more efficient and effective care to these patients living in rural communities.
Thank you. It's a very complex problem, and it sounds like there are a number of angles from which we need to address the problem, both from social determinants of health as well as education of practices, increasing access, and policy changes. We really appreciate you taking the time to be with us today for this interview. We look forward to the session at QCOR and appreciate your participation in that, and really appreciate all the work you're doing in this area to help further the mission of the AHA.
Thanks so much for having me.